menopause means you've apparently reached a certain age or a certain point in your life. So a lot of the wear and tear that's already happened on your joints is there.
Mm.
As mentioned before, we can't reverse it. So on top of losing the protective estrogen effects, you have the underlying changes in your cartilage.
Are you a busy woman who prioritizes everyone else's health above your own? Do you have questions about your diet, exercise, or how to prevent or treat certain health conditions? Are you always Googling health questions that you forget to ask or are embarrassed to ask your primary care physician? Girl, do you even have a primary care physician? Well, welcome to Headed to Healthier. I'm Dr. Brittany Anderson, a board-certified family medicine physician, and every day in my private practice, I have discussions with women just like you who are doing their best to juggle the demands of life while also desiring to become healthier. Inside this podcast, you'll find practical and actionable health tips that you can incorporate into your daily life. You'll get expert advice and insight from some of my awesome healthcare colleagues, and you'll hear relatable conversations with incredible women just like you who have made their health a priority and are thriving because of it. So throw on your sneakers and get some steps in while you listen. Or if you're driving, get those hands at 10 and 2 and let's dig in. We are headed to healthier. Hi, everyone. Welcome back to today's episode. We're so excited for this episode. We're calling it Knee Deep in Health, Understanding Knee Pain with Dr. Shawn Johnson. I'm honored to have Dr. Johnson join us today. She is a board certified orthopedic surgeon. I know she's very busy, and Dr. Johnson, I appreciate you taking some time out of your schedule to chat with me and with my listeners today. I wondered if you would just introduce yourself to us a little bit, and then we'll get into some questions for you.
Okay, well, thanks for having me. I'm Dr. Shawn Johnson, and I have been practicing orthopedic surgery for what will be 17 years this year. I'm board certified in general orthopedics and sports medicine orthopedics. And I currently own my own practice in Houston, Texas, and happy to be here and talk about some common knee pain issues.
Great, thank you. And I left out the sports medicine certification also, and so that is awesome and really gets to our point today. You know, our listeners are mostly female and have a myriad of health questions and concerns. And just in polling a group of friends before I started the podcast about what they would be interested in hearing, so many people mention joint pain, specifically knee pain. I am general family medicine and I see a lot of knee pain in my clinic, but I also certainly refer a good bit of it out. So happy to have you to help answer some of these questions that I know many of our listeners have today. So one of the first
Yes.
things I wanted to talk about is, you know, many people experience knee pain, whether it's male or female. I wondered if you would go over some of the more common causes of knee pain that you see in your practice, and then maybe even also talk a little bit about the difference in the presentation of knee pain in men versus women.
My main population is probably more my age, maybe a little bit younger. And once we get there, it kind of separates. Men, I tend to see have more traumatic things go on, and that may be biased a little bit by population. I have a large workers' comp population in my current practice, and a lot of those are men with laborious jobs, so they have more trauma associated with their presentations. The women tend to have more overuse complaints, or they're starting to develop arthritis. Many people look at arthritis as a problem that you get when you're a lot older, or they only think about arthritis being the worst level of arthritis. But the way I explain it to my patients is that number one, our cartilage is not meant to last forever. Cartilage does not heal itself, it does not repair itself. It's like adult teeth. Once you lose it, it's gone. You don't get it back, which is why arthritis is such a huge problem in the healthcare community, but it's a continuum. So from 0 to 10, you may have 0 where your cartilage is pristine, no issues, and then 10 is the bone-on-bone arthritis, which means all or most of your cartilage is gone for whatever reason. and you don't have any other protective layer of cartilage. But anywhere along that continuum, you can present with discomfort. So a lot of what I end up doing is just educating my patients on what arthritis is, why you may or may not have it, because there are a lot of different reasons why people can develop arthritis. Arthritis itself is the loss of cartilage. How you get there varies completely on your past medical history or your past injury history. I would say more so for men, middle-aged, history of injury specifically, they can sometimes trace it back to a specific injury. Women, more so overuse, and then just as we get older, quote unquote, wear and tear. But a lot of people don't realize that something else in their past medical history has sometimes led to the development of their arthritis, whether it be a rheumatologic disorder or a history of an infection in the joint or trauma or, patients that have hemophilia, things like that. All of that affects the cartilage and could lead to different changes within your cartilage and lead you into the office.
All right. Would you mind? You mentioned overuse injuries and in arthritis, how it can be related to overuse. Would you mind just talking just a little bit more about that for the listeners to understand what you mean when you say that?
So overuse. So if you think about overuse, say in the adult population, I get patients that come in and literally say, I'm very active. I run every day. I run up to this many miles a day and this many miles per week. I ask, well, is there anything else that you're doing? Like for exercise, and usually it's no. There's no weight training, there's no cross training, there's no bicycling, no swimming. So if you think about your joints, yes, joints are meant to sustain stress. We walk every day. Most of us walk every day just to do everything we need to do to get from point A to point B. But if you think about like the tires on a car, the more you drive and the more rugged your terrain is that you're driving over for whatever reason, you're going to wear your tires out quicker. So I explain to patients, and I hardly will ever tell them you don't need to exercise or you don't need to run, but I'll have them modify their activities day in and day out or week in and week out and try to understand. And even for professional level people that are runners, that's not all they do is just run. They have weight training regimens. They have cross training, meaning they choose a different activity to work on their cardiopulmonary health and endurance other than just running. So, and I think a lot of patients that we see, of course, are not professionals, but it really is important to look at yourself as an athlete. If you are participating in exercise and regular exercise, you need to consider rest. You need to consider nutrition, weight training, et cetera, et cetera. And I don't think a lot of people understand that. And the more wear and tear you put on your joints, the cartilage is going to wear. So somebody that does not participate in any exercise, they may not have the same type of joint problems that the person who runs every day has. They may trade those in for some other health concerns. And if somebody does not walk, is not able to walk, of course, they won't have the same types of joint presentations with overuse and wear and tear on cartilage, but they'll present with other problems. So the overuse usually comes in the form of people just not knowing and understanding that it's not the best thing to do the same types of exercise over and over and over and not give your body a change up.
Right. So
Uh-huh.
so it sounds like what you're saying is that if we, want to be more active, that we need to spread it out a little bit, not only
Mhm.
be running, but making sure that we're getting some weight training and, perhaps some
Mhm.
lifting or other types of exercise cross training you mentioned also. So that's really important.
I mean, it's if you're a runner and you run at a track, a lot of times you will see a notice sign on the track. Monday, Wednesday, Friday, they want you to run in one direction around the track. Tuesday, Thursday, Saturday, for instance, they want you to run in the other direction around the track. And that's just to decrease the wear pattern on the track. If everybody ran around the track the same way, 365, then that track is going to wear a certain way. But if they have you reverse how you run on the track, then it helps to save the track. But you can think about that in the form of your joints just as well.
That's fun. I've seen that many, many times, but never even thought twice about why they have you run in a different direction
Mm-hmm.
on different days. So that's funny.
Mm-hmm.
A little extra bonus. Thank you for that. So, when we think about women in particular, as we know that hormonal changes, especially during menopause, can impact joint health. Would you talk just a little bit about how this affects joint health in general, but specifically the knees, and if there is anything that women could do to kind of mitigate these effects?
So even for me, when I first started trying to put menopause and joint pain together, I made it a little bit more complex than what I needed to do in my brain. So if you just break it down as we go through menopause, we have hormonal changes. Estrogen is one of the main hormones that we end up seeing a flux in, and estrogen has anti-inflammatory traits. So simple enough, you have less protection over some inflammatory type symptoms, and as your estrogen fluctuates and drops down. A part of that also, menopause means you've apparently reached a certain age or a certain point in your life. So a lot of the wear and tear that's already happened on your joints is there. As mentioned before, we can't reverse it. So on top of losing the protective estrogen effects, you have the underlying changes in your cartilage that are just there because you've lived a certain length of time. With hormonal changes, you can see some changes in your metabolism that can cause weight gain. That weight gain can cause extra stress on your knees or on your weight-bearing joints. You put the weight gain together with the hormonal changes, but at the same time, even if you are not perimenopausal and not menopausal, if you put on weight, you're probably going to see increases in joint pain because there's extra stress on your joints. And then as we get older and our changes in estrogen can lead to decreases in bone density, can lead to weaker bones, obviously, and the same amount of stress that you would put on healthy bones, on weaker bones can lead to bone discomfort, bone, of course, fracture for certain levels of osteoporosis or decreased bone density. Along with that, it just kind of goes down the line. The less we do, we may not have, or we may start to lose our muscle mass. Our muscles are important. They help support our bones and joints. That's why for a lot of people that come to see me, they don't understand, well, Dr. Johnson, you said the cartilage is not going to come back or we can't repair it. Why do I need to go to physical therapy if all I have is arthritis? Well, our muscles help to support our bones and joints. And if we can keep our muscles strong around our bones and joints. For instance, people that come in to see me with knee pain secondary to arthritic changes, I send them for lower extremity strengthening, endurance and balance training to help support that joint.
And so it sounds like you're saying that kind of once we're at the stage of menopause already and we're having less estrogen, because that's what happens when we go through menopause, it's all these other compounding factors as well. So age plays a role, and age, as you mentioned, tends to go kind of hand in hand with menopause in most cases. But the weight also, and that is one that perhaps we can affect some change as opposed to the decreased estrogen and the changes in age as well. So it sounds like it's multifactorial for sure.
It is. And I think we think about menopause and we're like, ugh. But there's a lot of things that even if we did not have to go through menopause, if that wasn't a stage of a woman's life, as we get older, some of these things are just going to happen anyway. And it's amplified by our decrease in estrogen. I think that's a safe statement to make.
You mentioned kind of some of the things that you do for your patients, like prescribing physical therapy and other treatment options for them. Many people may wonder, my patients will come into clinic and, we kind of have that discussion of, hey, when do we need to go see ortho for this? Or even before then, at what point my patients need to come in to see me as their primary care doc for it. What do you find is kind of that tipping point between this is just run of the mill knee pain, or you need to get into your primary doc and maybe your primary doc needs to get you into an ortho doc?
So if somebody's having pain that is becoming more persistent and reproducible, and they have not been able to figure out like how to mitigate that, I always say go see your doctor. If you can see your primary care doctor, great. If you have the ability to go directly to see an orthopedist, I think that's fine also. Usually at those initial visits, of course, we get your history and do an exam. And then basically well, at least in my clinics, we have a discussion if we're looking at arthritis as the underlying issue. Now, other things that kind of are red flags for me or catch my attention more so than discomfort, because discomfort is so subjective, right? The things that get my attention are swelling or effusion, catching or locking, which people have a hard time conceptualizing that unless they're having it.
Right. Once they feel it, they know it, right?
Right, exactly. So if I say, and usually, you know how we learn in medical school, when you're taking a history, you try not to lead the patient, you just try to have them tell you their story. So if I say, are you having catching and locking? Some people will say, you know what? That's what that is. I did not know how to, excuse me, how to describe it.
Couldn't put
But
into words, right?
that is what's happening. So if people are having, like, they feel like something is rolling around or catching inside their knee, that's something that's important. Any signs of, infection or inflammation, redness, heat, anything like that. And of course, if you have an all-out injury, those are the things that kind of get my attention. A joint does not swell for nothing. That's just the truth. Now, whether or not we can find out quickly why it's swelling, that's another story. But most of the time, if a joint is presenting with an effusion, there's something underlying going on. The catching under locking is usually significant for cartilage that is unstable in the knee, whether it's torn meniscus, which can also happen along with arthritis because meniscus is cartilage also. So as it starts to wear, it can fray, it can tear without having a significant incident. And then the cartilage on the ends of the bones or your articular cartilage can wear and it frays. So sometimes you get little flaps of cartilage that get flipped over or pinched or caught, and that causes that mechanical symptom of catching or locking that you have. Usually, if you're having those, nobody's going to fault you for coming in to see an orthopedist for sure.
Right.
You know,
Right.
and then
Absolutely.
if you get to that point with your primary care doctor, as the first step, we do plain films. I always encourage people to do plain x-rays. Somebody who is usually 50 and above, I'll get bilateral weight-bearing knee films to compare. And when I show them their films, and I always show my patients, I shouldn't say always, I don't like to say always or never, but I try my best to show my patients their films. They can look and say, oh, I see
Mm-hmm.
why that one
Mm-hmm.
might be more uncomfortable. And that does
Right.
a world of good for somebody who's trying to figure out why X, Y, and Z is hurting. Now, I know a lot of primary care doctors that are pretty comfortable with managing new onset knee pain. And for those primary care doctors, once you get to the point where, I've done this, I've done this, I've tried anti-inflammatories, we've discussed weight management, and even maybe started physical therapy if you've not found anything structurally abnormal. And then once you get to the end of, what you feel like is your comfort zone, then by all means, send them on. And then we can start talking about things that are a little bit more invasive, like injections and things like that.
Right, and that's great. I wanted to actually get into that. Sometimes I worry that when I do send my patients to ortho, or to any surgery specialty, they think that I'm sending them straight for surgery. And you just hit
Oh,
on
yeah.
that there's several things that we do between there. And so once
Yeah.
patients have already tried some medicine options by mouth, maybe anti-inflammatories, or have done physical therapy if that's been started, what other kinds of things are options for knee pain before going to surgery that patients sometimes may not think about or that we have to have that extra discussion about?
Well, there's a lot of different things. Let's kind of try to just talk about, say, arthritis. So I always start my conversation with patients, and I'm a surgeon. I love to do surgery. Yeah, I love it. But I always talk to my patients about the fact that arthritis is just that. It's wear of your cartilage, and it is not going to kill you.
Mhm,
It is not
mhm.
your heart, it's not your lungs, it's not your kidneys. This is something that if you learn to live with, you can live with it. It may make your life uncomfortable. It may cause you some good days and bad days, but I am not the type of surgeon that basically comes in and says you have to have XYZ done to your knee because you have arthritis. With that said, the different levels of treatment that I go through, number one, you can do absolutely nothing. You don't want to do anything to treat your knee arthritis. You just want to know what you have and to make sure you aren't crazy, then we can talk about that. I start with medications by mouth if they can tolerate them. Some people are not able to take anti-inflammatories. That's going to push them down the line of treatment a little bit quicker. If patients aren't able to tolerate anti-inflammatories by mouth, I will attempt to try topical anti-inflammatories,
Mhm.
specifically with the knee because the knee is fairly superficial. You can palpate, and the patient can have symptoms from the palpation, and you can put topical anti-inflammatories, topical pain relief directly on, and people can get some relief from that.
So
If
that's
a
great that you
patient,
say because I love topicals, especially for my
uh-huh,
patients that have issues with taking anti-inflammatories by mouth. I realize they don't always help, but I do
right,
offer them a lot. So it is really good to hear you say and a lot of those, or some of those, can just be picked up over the counter, right? So I think
right.
about, some they can get over the counter, certainly their prescription options, but that's good to hear you say.
Definitely. And I tell them, it may or may not work, but it's worth a
Right,
try.
right.
As long as you're not allergic to anything that's in it, by all means, give it a try and understand that it's usually not going to be it gets better right away. It's not gonna, it doesn't happen like that. The other options for arthritis and just for overall joint health is I will discuss joint supplements with them, like glucosamine and chondroitin, to help with nourishing cartilage that you have left. Again, it does not give it back to you, but it helps to nourish what you have left. And it is also a supplement or a vitamin. It's not going to work overnight. So it has to be given 6 to 8 weeks regular use to see if it's going to make a difference. And I get a lot of patients that say, I don't think this is helping me at all. And I say, okay, well, stop taking it.
Right.
And then when they stop taking it, they say, well, I think it was helping. I say, okay.
Right.
Well, go back to it. And then we get to steroid injections. So steroid injections for me, I use them in patients that have arthritic changes that I'm usually able to visualize on x-ray, meaning they are a little bit further along with their cartilage loss. And usually if they present with effusion and pain, swelling, etc., that has not been managed by any of those things we just talked about. Very seldomly does a patient come into my clinic the first time ever. And if they've not tried anything else, I usually will say like, hey, there's some things we can try before I inject you. Of course, that it does make a difference, how bad their symptoms are when they show up. Some people wait forever to come in and they need a bit of a rescue before we can get them on something by mouth. I didn't mention one of my really, really, really favorite treatments when people first present is a Medrol dose pack, if they're able to tolerate it.
Okay, so like a steroid dose pack?
Before I do an injection, I like to try a Medrol dose pack if they're able to take it. The steroid injections, along with the steroid, I also inject some numbing medicine. So that gives them a pretty quick relief with the numbing medicine. And then the steroid usually takes effect in about 24 hours. Some people, if this is their first presentation, that steroid injection can calm things down. I'll place them on an oral anti-inflammatory if I can, immediately following that. And that may do it for them for a while until they have another flare. You can get a steroid injection up to every 3 months. I don't do them more frequently than that. Some of my patients, for one reason or the other, that's just how they manage their knee arthritis. They come in and get a steroid injection.
Yeah, I have a few
Yeah,
patients in clinic who are there who say, you know what, I don't want surgery. My
right,
injections last 4, 5, 6 months or so, and that's what they do, to prevent
right,
having to go to surgery unless it gets to a point that, they just
right.
absolutely can't
And
get
usually
can't
when
get there.
they come back to see me, we have a discussion. Each time we have a solution for your knee arthritis. Whenever you get to the point where you want to explore that solution, we can talk about it. The other types of injections that people always ask me about are the visco supplement injections. And
Yes.
the thing about those is that they're meant to help maintain the cartilage you have left. You can't just inject it and it's going to all of a sudden give you this new wonderful cushion in your knee.
Right.
That's not how it works. So some people are radiographically beyond that. However, depending on the patient and their presentation and their situation, when it comes to risk benefits, as far as that injection is concerned, if they're like, no, I just really want to try it, I'll make sure they understand that this may not be helpful for them. But in the
Hmm.
grand scheme of things, it's not necessarily hurtful either. So
Hmm.
I will try those things. The one thing that I left out, and maybe not left out, but I also do bracing for people, which is why the standing x-rays are so important. Most people present, especially early on, their wear and tear is in a particular compartment in the knee. Sometimes people present and it's in all three compartments, but if it's just in one, sometimes I can get them fitted with a brace that will unload that particular compartment and give them relief during their weight-bearing activities. There's a lot that can be done before you get to surgery. Depending on where you are in that continuum of arthritis and treatment is usually where I talk about starting with you. And like you said, most people think, oh, if I go to the surgeon, that must mean I need to have surgery. Well,
Right.
no, not necessarily. You may have an indication for it, but just because you go to a surgeon's office does not mean you have to sign up for surgery, at least not with
Right.
orthopedics. I'll put it like that.
Exactly.
And there's a lot of different things you can do to help mitigate those symptoms. But do know that once you've exhausted all those things, the surgeon may literally say, there's not much else we can offer you. And then at that point, everybody just has to make a decision. But I have never told a patient that I've done a knee replacement on, you have to get this done right now. No, you'll come find me when you're ready.
Exactly. I tell my patients that all the time. I say,
Hmm.
for knees and shoulders, I say, you'll know when
Yeah.
it's time. And I
Yeah.
think very often
Yeah.
they do. As we sum up a little bit, I wondered, and you've already hit on all these. I just wanted to have them as kind of a closing point for my listeners. What do you think are some preventive measures that listeners can take to maintain healthy needs and to avoid kind of future injuries or issues that may lead them to your office quicker than they otherwise would get there?
Well, maintaining a healthy weight is
Hmm.
always important because that's going to decrease the stress on your knees. Regular activities, staying active and staying mobile, it not only helps you. So knees, joints in general like to move. So when things get stiff because of disuse, joints hurt when they're stiff. They just do. So staying active, that also can help maintain your muscle mass. Case in point, during the winter month, arthritics usually have a harder time. And usually that's because, or part of the reason is because they're just not doing as much. It's cold. They're not outside working in the garden, or they're not outside, and things just get kind of stiff and tight. So I encourage people to stay active. The bone health for women and men, but in particular for women, your calcium and vitamin D levels, and making sure your bone health is up to par. The supplements for the cartilage are an option to maintain healthy cartilage, but again, it's not something that I can guarantee is going to, help for everybody, but the side effects of it are pretty low. So it's something that I feel like people can try. And I think that's pretty much it. Staying active, keeping your weight controlled, bone health, making sure that vitamin D and calcium are included if you're after a certain age, and then getting your bone density checked specifically for women. But
Right. There also is a lot of information on your website just about general health and ortho in specific. I know that you are based in Texas. Your practice is in Texas. So if any of my listeners are in the Texas area and want to find you, I know that you've got some telemed options and then your clinic is there also. But wondered if you'd share just your website or any information about how listeners can find you.
Well, my website is www.dr, so Dr. Shawn, SHAWN, MD, ortho.com. And through my website, there's also links to my Facebook and Instagram. The telemedicine option that I have, you can find the link on my website, and it basically gives people an opportunity to meet with me via telemed for a short visit to determine if that patient needs to see an orthopedist. Sometimes, and one of the things I really try to prevent from happening is a patient being scheduled to see me, waiting to see me, and then they get to me and I'm not the person for them. So I try to prevent that by speaking with them ahead of time and trying to get them, going in the right direction. So yeah, those are the easiest ways to get in touch with me.
Well, thank you again so much for taking the time out of your day. I know that you're busy, but we appreciate you coming onto the podcast to speak to me and to my listeners today. And we hope to perhaps have you back in the future. In addition to knees, there were lots of questions about shoulders, so maybe we can
Yes,
get you back sometime in the future to talk about that also.
that sounds good.
And to you listening, I hope you learned a good bit about knee pain today. Some of the common causes, treatment options, and when you may need to see an orthopedist. If you're in the Texas area, be sure to check out Dr. Johnson. She is awesome. I will link her website information in the show notes. And if you know someone who's always complaining about their knees aching, make sure you share this episode with them. Talk soon. Bye. Hey, thanks for listening in today. I hope something you heard in this episode will help you on your journey to becoming healthier. Remember, this podcast offers general health information. I am not your personal physician. If you need advice that is specific to you, be sure to consult your physician. If you enjoy this podcast, please consider sharing it with a friend and reviewing it on Apple Podcasts. Also, be sure to subscribe to the show so you never miss an episode. Tune in next week for another great episode of Headed to Healthier. Until then, take care of yourself. Talk soon. Bye.